When we have a patient where we have a high assumption of gallbladder association with their abdominal pain or issues, we're going to do a particular assessment where we're going to focus quite a bit on history of, well, a social history as well as a pain assessment and a pain history. So our history for a gallbladder assessment really has quite a bit to do with nutritional aspects of the patient's life as well as just their metabolic life. So we need to have the patient's height, weight, and vitals. Because this is an inflammatory process, we might see an elevated temperature, tachycardia, and then potential for dehydration from fever and vomiting. So that could affect the weight of the patient, especially if we know their baseline. As we continue on to the history of our patient, we should talk about their food preferences, their diet preferences. Do they have a diet that has excessive fat and cholesterol, high calories, low fiber, high in refined white carbohydrates? We need to check all these out because these are all risk factors for gallstones. Asking them if any particular food causes pain, or if they have any GI symptoms when they eat specific foods, like fatty foods. Do they feel worse when they eat fatty foods? Do they have a lot of gas or burping, dyspepsia, which is heartburn, anorexia, so any just kind of disinterest with eating, nausea, vomiting, abdominal pain or discomfort. And then, of course, if they do have pain, we need to do a full pain assessment to assess how often, when it started, what they rate their pain, how they describe it, etc. Does our patient engage in daily exercise or activities? What is their presentation? Generally, patients with cholecystitis present with abdominal pain. So like I said, we need to do a full pain assessment. We want them to describe their pain, including the intensity and duration, those precipitating factors like food or what relieves it. Sometimes we see patients who have cholecystitis with right upper quadrant pain that actually radiates to the scapula or the upper back, which sounds quite a bit like cardiac. So these are things that we cannot rule out, especially if we're triaging. Biliary colic is pain that's produced by obstruction of the cystic duct and that's because of gallbladder or movement of one or more stones due to the tissue spasming. So when the cystic duct is obstructed by a gallstone or the cystic duct is spasmed because of the moving of a gallstone, that's when we have biliary colic. So the tissue, much like what we'll discuss in future chapters about when renal stones are passed through ureters, when a gallstone is moved through the cystic duct, we're going to have some spasming of that tissue, and it's going to cause pain, which is considered biliary colic. Diagnostics, some of our serum labs, all of the following serum labs might be increased, like white blood cells, because we're going to see inflammation, alkaline phosphatase, AST, ALT, and those three would be elevated, and if they are, they're indicating abnormal liver function, and that would be due to biliary obstruction. Direct and indirect bilirubin, amylase and lipase, and that would be if the pancreas is involved. On an x-ray, we might see calcified stones, but if there are stones that are not calcified, we won't see those on an x-ray. So that would be where we would use an ultrasound. Ultrasound is usually the best and first diagnostic tool that we use for cholecystitis. Generally very painless, it's safe, and we get really good information from it. A hepatobiliary scan or a HIDA scan can be used to determine the patency of the biliary system and view the gallbladder. It's a nuclear medicine scan, and it is described in detail on page 1216 of your 8th edition of IGGI. What it does is it determines the rate of ejection of bile into the biliary duct. So if we see decreased flow of bile, that indicates that there's gallbladder disease with obstruction. We've talked a couple different times about ERCPs, so we won't discuss it more here, but this is also used for gallbladder assessment. MRI as well. Non-surgical management of cholecystitis oftentimes includes medication. Usually our patients who have cholecystitis are going to require opioid analgesia, but we have to consider the fact that this can cause spasms in the sphincter of Oddi, so this could increase pain. It could increase that colicky pain, so we have to consider that. Ketorolac is an NSAID that can be used for inflammation, but like all other NSAIDs, it could cause GI bleeding, so we need to be cautious with that. Antiemetics are probable with patients who have cholecystitis. Antibiotics are possible, and a small percentage of people with gallstones can use a bile acid dissolution agent like ursodiol or quinadiol, and those would be given for a very extended, up to a very extended period of time, like 2 years. And what that does is it takes those stones and essentially just makes them not get any bigger. So it stabilizes them or dissolves them. They need to be monitored by ultrasound, and those medications should always be taken with food. Extracorporeal shockwave lithotripsy is what it sounds like, extracorporeal, outside of the body, shockwave lithotripsy to break up stones. So we're using shock waves outside of the body to break up stones. This is used for patients who have cholesterol stones and good gallbladder function. Patients might experience some pain during this procedure, and what that is once again, like we talked about, those gallbladder spasms or the spasms of the duct, so ductal spasms as parts of the stone move through the duct or the gallbladder. After this procedure, we might see patients on bile acid, and that would be helping to break the stones up even further. Some patients will end up with a biliary catheter or drain. We would see this placed during CT or ultrasound, and all that does is kind of acts almost like a stent, and it opens up the ducts so bile can flow through. It could be internal or external. An internal drain is drains into the duodenum, whereas an external drain drains into a pouch, almost like a stoma. Cholecystectomies. A laparoscopic cholecystectomy is when we remove the gallbladder. Really, the gallbladder is kind of superfluous. All it does is acts as a reservoir for that bile. So if we need to remove it, we can. Acute infection of the gallbladder does indicate emergency surgery. Why would we use laparoscopic versus traditional? Well, laparoscopic is a preferred method because it has considerably less recovery time, less post-op pain, minimal scarring, it's less expensive, and it's often even used as an outpatient surgery. Complications are way less common, and there's a lower death rate. It's also rare to have injuries of the bile duct. For postoperative care, we can anticipate that they'll have antibiotics before or during the first incision during surgery. And it may be indicated after surgery as well, but it may not. Nausea and pain control should be used. Ice might be indicated. Folks recovering from a lap chole or a laparoscopic cholecystectomy might not need opioids for as extended of a period of time as a traditional lap chole, but they'll probably be given the option of some. Some folks might utilize heat for the referred pain, and we see referred pain in many thoracic laparoscopic surgeries because of the carbon dioxide that they use to inflate the thorax or the abdomen to get the scopes in as well as the other tools. Wound care, incisions for laparoscopic cholecystectomies are pretty small, but we need to educate patients on what to look for infection and monitor them ourselves while they are inpatient. Lap chole patients might have to follow a low-fat diet, but a lot of them return to their normal diet after surgery. There is a possible complication with any kind of cholecystectomy, laparoscopic or traditional, that is called post-cholecystectomy syndrome. And in this syndrome, people experience abdominal pain, nausea, vomiting, and diarrhea, and this can happen weeks to months after surgery. The causes of post-cholecystectomy syndrome are found on page 1218 in your 8th edition. Table 59-2, common causes of post-cholecystectomy syndrome. And when this happens, we might end up seeing a patient back in the treatment room. They might need to have an ERCP to find the problem and repair it. Let's compare a laparoscopic cholecystectomy to a traditional cholecystectomy. Really, a traditional chole is going to be just the standard pre-operative care with medications and drugs and surgical prep as far as diet and cleaning, etc. Traditional approach might be chosen if a patient has severe gallbladder disease and the ducts need to be explored. Like if they're not sure if the duct is patent or not, they might choose a traditional chole. Generally, a patient is going to be inpatient for 1 to 2 days after a traditional cholecystectomy. A diet can usually be advanced from clear liquids to full diet in a day or less, but they are going to be advanced a little bit more slowly until we can guarantee that peristalsis has returned. Patients might have drains placed, and they oftentimes are going to have antibiotic therapy. They'll be potentially using opioids via PCA or patient-controlled analgesia, and antiemetics. Have to be talking about wound care and continuation of nutrition therapy for these folks as well.